Good afternoon, ladies and gentlemen. First, I would like to thanks to the uh, cholangiocarcinoma Research Institute that invited me to be a speaker here. And the topic I will talk today is the ERAS perioperative care in hepatobiliary pancreatic surgery. Basically, I'm the general surgeons and colorectal surgeons who work in the Surgery Hospital. You know, the patient I have take care of is not only the hepatobiliary, but include the colorectal surgery. And the contents I will talk is covered in 4 topics: the management of the surgical stress, and the principle of enhanced recovery of the surgery, the care pathway to recovery wells, and lastly, the effective of the outcomes. I'm not intend for all of you to get and after go back to your work can implement all of the ERAS in your daily practice, but keep the awareness of the importance of ERAS protocol to your practice. And before going into the detail, I would like to share the key message that about 82% of the hepatobiliary patients can be well tolerated with the diet on the post-operative day 1 if you follow the enhanced recovery after surgery program. And of course, if you adhere to the ERAS protocol, they can reduce the length of stay from 3 to 6 days. And with these adherence, the patients can now increase the readmission rate and the morbidity. And some of the patients we have done in our practice, for example, the difficult case of the PD, pancreatic duodenectomy, this may have some experience of the delayed gastric emptying, but you know, the ERAS protocols can reduce the delayed gastric emptying for this patient about 50%. Now I'm going into the main concept of the ERAS. The main concept of the perioperative care is to do the patient return to the normal function as fast and smooth as possible. From the figure, you can see that many stressors appearing during you do the operation. Many of them have the result of the treatment. For example, the patient's experience of pain is from your surgery, and some of the complications related to your surgery is also. But some of the stressor is related to the traditional management. You may familiar with the prolonged NPO time. And at this moment, many of the surgeons and anesthesiologists trained to have the prolonged NPO from after midnight. That is not necessarily for the patient who do the operation in the afternoons tomorrow. So after the patient have the operation, they have the same situation like the injury patients. The reactions of the body to the injury or the operation is the insulin action, which is the under the normal situation. But in the major operation, they just have some of the insulin resistance that's cause of the surgical stress. If you look at this figure, you can see the very small incision like a laparoscopic cholecystectomy. It has the about the minimal invasive surgery comparing to the open colorectal surgery. It has the very big stress to the patient, and we can see that the patient have some of the increase the insulin resistance there. What happened to the insulin resistance to the patients comparing to the diabetes patient? It is the same way. They have the increase of the glucose level and have the glucose reductions in both of them, the DMs and the stress patient who have the insulin resistance. And of course, there are difference because the diabetics patient have the complication related to the insulin resistance, but it takes time, slow progression, maybe and develop in months or year, but contrary to the major surgery. They have the insulin resistance and cause of the complication in days. So what is the complication after surgery? I think every surgeons know they have effects to the immune system and cause of the infection, not only the surgical site infection, but of course to the pneumonias or some of the infection, sepsis and other like this, and have some effects to the vascular neurons and the kidney. And here is the status of the ERAS in the colorectal surgery. The ERAS have effects to the insulin resistance and have reduced the complication by 30%. And of course, if you look at the length of stay in this group of the patient, they can shorten the length of stay by 2.4. How about the hepatobiliary surgery? It just can shorten the length of stay by 2.2 days too, like a colorectal surgery. This is the same way. Why they can reduce the complications and reduce the length of stay. If you look at this classic photo, after you doing the operation, the functional capacity of your bodies can drop abruptly and have long periods to restore to the functional capacity at the level before doing surgery. But if you prepare very well the patients before doing surgery with the ERAS protocol, you should whereas the ERAS is not only the post-operative care, it includes the pre-operative, intraoperative, and the post-operative phase. In the concept of the traditional care, after you do the operation, your functional capacity is dropped abruptly, and you have NPOs for a long time because you're not sure that the patient can receive the post-operative drinkings or post-operative intake adequately in the short time periods of time that makes your patient have some problem with the malnutrition seriously. If you change your practice to do the ERAS protocol, of course, you have times to prepare your patients before doing surgery. You have the schedule 2 or 4 weeks before have the operation. And that's the golden period for you to prepare your patients as well. We call this is the rehabilitation. Some of the activity we have such as for the patient is stop smoking, have some of adequate food intake, include the calories and protein intake, and maybe some exercise just appropriate before doing surgery. We focus in the breathing exercise because after the doing major surgery, the patient some experience difficult to exercise as well. So in this group with the ERAS protocol, they can recover to their functional capacity in a short periods of time. We go back to the insulin system. What we can treatment or manage of the insulin system. You can see there's the red box. That's we have many options to dealing with the insulin system. For example, the fasting or the carbohydrate loading before doing surgery. It's just so simple, but I think many of our practices not include the carbohydrate loading in our patients. And the thing that we are quite familiar is the laparoscopic surgery. It is the minimal invasive. You can imagine that the minimal invasive can have less stressors compared to the open surgery. And the key point is the adequate pain control, not whether the small side incision or the big incision. If you have adequate pain control, the patients can recover and have the early mobilization as well. And the post-operative food, okay, is very important. I'm going to the special metabolic list group. Start from the malnutrition first. About half of the patient we are doing the hepatobiliary surgery have carried the malnutrition at the time we are scheduled for the surgery. So we have suggest that you should have the screening and assessment of the malnutrition status before doing surgery. If you found that your patient have the moderate or severe malnutrition, it is our duty to manage the malnutrition before doing surgery. Why? Because the malnutrition is related to many complications. And how to manage the malnutrition with the adequate calories and protein at least 7 to 14 days before doing surgery. We don't intend to have the patient return to the normal weight, but after they get the adequate calories and protein, they are prompt for the surgery. And if we have more times, the prehabilitation should take 4 to 6 weeks before surgery. If you have some limitation because of the tumor may be progressed before 4 to 6 weeks, that means the patient still have the risk of the malnutrition too. And the group of the patient with diabetes, some have the high risk of complication itself because the poor control of diabetes is related to so many complications. And the patient with cancer. This is the 62 patients with CA lobolectomy and undergoing the other low and zero resection. This is the postoperative day 2. The patients can getting off the bed and walk around the bed without any assistance. With the preoperative, with the ERAS protocol, which very do themselves with the relative. If you adherence to the ERAS protocol as well at the high level, the highest is many of the level. Some literature is classified more than 60% is high, while some literatures classify 7 or 80% adherence to the protocol is the high compliance. As of course, as the high levels of adherence can improve the patient and benefits of them. This is the long-term survival in the patient with colorectal surgery. This high compliance, you can see there's much different before the compliance above 70% compared to the low compliance at below 70%. If we compare to the cholangiocarcinoma, this is the paper from Konkan University published last year. It is a retrospective cohort study to evaluate the feasibilities of the enhanced recovery after surgery in liver dissection for CCA. And they categorized the patient into 2 groups. One is the compliance above or equal to 50% compared to the other group that's adherence below 50%, what they have found. The compliance, they don't do as well as the pre-anesthetic anxiolytic or DVT prophylaxis and some of the fluid management directly to the goal-directed therapy. But the item that they do very well is the model analgesia and the early post-operative feeding is much better. If we do the compliance greater or equal to 50%, they have much better for the outcome. Both the short-term and the long-term outcome for the patients. Comparing to the intraoperative, intrahepatic cholangiocarcinoma, the patient who have adherence to the protocol greater than 50%, have much better in the survival rate. And again, some of the category have some that disturb the homeostasis. For example, the bowel preparation. It's not so important in the hepatobiliary surgeons, but they must be concerned by the colorectal surgeons. The bowel preparations make the patient dehydration before doing surgery, and some of the loss of the electrolyte imbalance before surgery. But both in hepatobiliary surgeons, colorectal surgeons have to concerns about the preoperative fasting. As I mentioned before, the NPO guidelines is clear that the NPO need for 6 hours for the solid food, and the patient should allow to have the clear liquid diet before doing surgery at 2 hours before anesthesia. This is the great support from the Royal College of Anesthesiologists of Thailand. They have launched the NPO guideline, not for the surgeon, but they have the guideline for the young anesthetists to make sure that they have the evidence to support that the patient have benefit to have the clear liquid fluid at 2 hours before anesthesia, and have not increase the risk of aspiration or the aspiration rate. And the other thing that the anesthesiologist has concern, and of course the surgeon has concern, is the adequate pain control. We need the multi-modal approach for the pain control to adequate pain control, because if the patient still have the pain, they don't have the chance to early mobilization after doing surgery. And the other one is the post-operative nausea vomiting prevention. If you look at the factors that may increase the risk of post-operative nausea vomiting, there has many factors. The anesthesiologists have to assess the patient before doing the anesthesia. What's the type of the risk for the post-operative nausea vomiting? If the score is so high, they have many medication to manage of this patient. Because if the patient have the post-op nausea vomiting, they cannot eat or drink as we assume. One thing is the multimodal metabolic approach. If you follow to the ERAS protocol, the patient can minimize the insulin resistance by the early enteral feeding. The enteral feeding is can be done in the post-operative day 1. For our practice, the patient can allow to have the sip of the water at 4 to 6 hours post-operative if the patient has no contraindication for feeding. This is the key point. The contraindications that you should know that the water side is unstable. This is the absolute contraindication for feeding. Otherwise, have some of the patient have the GI breathing, we can delay the feeding. Of course, is rational for the post-operative feeding. If the patient have no contraindication for feeding, you should feed as early as possible. You can look at the, this policy. If you have the oral food intake, you have the chance to get the adequate calorie from the first day. And comparing to the traditional of care, the patient some have the allowed to shift feed in the post-op day 1, and the other one is allowed to have the liquid diet, and the third day should start from the solid diet. Is quite late for the patient to have adequate food intake. But in the ERAS protocol, we have the 6-hour interval. First 6 hours, they have allowed to have the sip feeding, and the 6 hours later, they have allowed to have the protein liquid diet, and lastly, in the 6 hours, can have the soft diet. 92% of the patients who underwent the hepatobiliary surgery can tolerate well with the feeding protocol like this. And how to managing the surgical spread by the principle of the ERAS and the FX outcome. If you follow the ERAS protocol, you can see that the main components focuses on the pain control to improve the gut function and early mobilization. To achieve this, you have to have the good multidisciplinary team, or we call the ERAS team. ERAS team is not means only the surgeons or the anesthesiologists, but include all the surgeon, anesthesiologists, the pain management team. And for the case of the colorectal surgeons, you can include the stomal nurse specialists, physiotherapists to have plan for the exercise before doing surgery and after surgery, and the team assistant. And the most important person is the patient themselves should be involved the team to achieve the ERAS protocol. If you look at the element of the ERAS protocol, this is the ERAS protocol starting from the colorectal surgery. It's quite similar to the hepatobiliary surgery ERAS program. I have this program from Japan literature. You can see most of the elements can be done in Japan. Only 2 or 3 categories, for example, the audits of the compliance outcome is quite variable in the Japan, not in Japan. I think many of the countries in Europe and America have varieties of the audit compliance. And the other thing is the prevention of nasal vomiting. I think it's not so hard to do the preventions of the nasal vomiting because we have many medication to do this. And lastly, no drain. I think in the most of the ERAS center, they are okay with the no drains policy or avoid to use the drain or use the drain as necessary. But some of the patients, especially in the liver cirrhosis, have the hepatoma. They tend to have the most massive ascites, so the drain is may help for management of these patients. And the other thing is the unit organization and the patient information center. This is not the duty for the surgeons, but all of the team should have the duty to do this information to the patient. And of course, if you want to do the ERAS protocol as well, you should have the discharge criteria. This is the example for the discharge criteria for in general surgery. The patient should have the good pain control with the oral analgesia, need know the parenteral analgesia. They should have adequate food intake and movements with no IV fluid. If you adherence to the enhanced recovery after surgery protocol, you have get a good result comparing to the ERAS adherence and the non-ERAS adherence. You can see that the ERAS compliance have the good result. They can recover more quickly than the non-adherence. And we subgroup analysis into the very high compliance compared to the medium or to the low compliance. It still have the difference in among this group. The high compliance have the good result. And lastly, the early mobilization for the post-operative. This is some of the study we encourage with our patient. The patient should spend out the bed at 2 hours in the post-op day 1 and 4 hours in the post-op day 2. And if they can tolerate well, they can spend out of the bed at 8 hours in the post-op day 3. I think this is the goal, but some of the patients cannot do this. Absolutely. So if we compare to the ERAS or the conventional care, the things that the ERAS is just like a patient journey. You can choose that. You can use the traditional trains or the high-speed train with the high early recovery with safety of the patient. In conclusion, with the ERAS protocol, it is the multimodal approach and need the multidisciplinary team to do this a great job. And by the ERAS protocol, they have the good support with the evidence-based. And of course, if the patient have adherence to the ERAS protocol, they have get the benefits from the ERAS protocol as well, comparing to the lower adherence. And lastly, if we follow this protocol as well, you have make the improvement of the outcome. Thank you for your attention.
Thank you very much.